Hello everyone, I am Dr. Divya Gupta, original guru of Periodontics at DBMCI, and today we will be discussing the questions of NEET GT4. In total, there are 14 questions in NEET GT4 from Periodontics, and first I'll be reading the question and the options. We'll discuss the explanation behind that question, and lastly, I'll tell you the answer. So the first question is, out of these, which is the first in the List-Garten stage of ANAC? Now, ANAC, guys, is one of the most important topic of the NEET and INI-CET. Every year, one question is coming from this topic. So, you must be very thorough with NUG. So, here the options given are the neutrophil zone, spirochetal infiltration zone, necrotic zone, and the bacterial infiltration of zone. So let us see the zones in NUG given by List-Garten are. Number 1 is the bacterial infiltration zone. Bacterial infiltration zone. So in this zone, first, what is happening in any disease? The first thing that is the first etiology of any periodontal disease is the bacteria. That is the plaque, right? So the first is the bacterial infiltration zone, and it is the most superficial zone. And it consists of various bacteria, varied amount of bacteria of different sizes. The second zone is the neutrophil rich zone. Neutrophil rich zone. Now, in this neutrophil rich zone, first the bacteria are coming. Okay, we have studied in the pathophysiology that when the bacteria are there, the first cells or the cells which come immediately at the site of infection, that is within less than 2 hours, are the neutrophils. So, next what will be happening is when the bacteria has entered, the immune inflammatory system of the body of the host gets activated, and the neutrophil will come at the site of infection and they will try to invade the bacteria. So the second zone is the neutrophil rich zone. It consists of numerous leukocytes. Now, the third zone is the necrotic zone. And in this, because of what happens when bacteria comes and the neutrophils come, there is phagocytosis of the bacteria. So here, what will happen? There will be many dead bacteria, degenerated epithelial cells will be present. So that zone is called as the necrotic zone. It consists of dead tissue cells. Remnants of connective tissue fragments, and numerous spirochetes. Okay. So this is the necrotic zone, which is the third zone of NUG, according to List-Garten. Now the last and the fourth zone is the zone of spirochetal infiltration. The fourth zone is the zone of spirochetal infiltration. Here, whatever remaining bacteria are there, they will cross the epithelium and enter into the connective tissue. It consists of large spirochetes. Medium and large size spirochetes are there. So it consists of well-preserved tissue. Connective tissue infiltrated with spirochetes. Okay, so according to this explanation, the answer here is, what is the question? Out of this, which is the first in the List-Garten stage of NUG? So the answer here is bacterial infiltration zone. Option number D. Okay, now the next question. Which of the following is the secondary manifestation of acute herpetic gingivostomatitis? Acute herpetic gingivostomatitis is what? It is an acute gingival infection, mostly commonly seen in children less than 6 years of age, right? Seen in children less than 6 years of age, and it has two stages. It is divided into an asymptomatic stage and a stage of secondary manifestation. So what happens is, what is acute herpetic gingivostomatitis? It is a viral infection. It is caused by a virus, and that virus enters into the body. It remains in a dormant stage in the trigeminal ganglion. Okay, there it remains in the dormant stage, and the primary or the first initial attack of the virus to the individual is asymptomatic in most of the cases. But sometimes, when the virus which is there into the trigeminal ganglion, which is in dormant state, it becomes active. At that time, it will produce manifestations. So, it is caused by this virus. Acute herpetic gingivostomatitis is caused by HSV virus, herpes simplex virus, HSV virus 1. Okay. And the secondary manifestations, of acute herpetic gingivostomatitis are herpes labialis, herpes stomatitis means inflammation of the lips, inflammation of the whole of oral cavity, stomatitis. Herpes genitalis, inflammation of the genitals of a person. Ocular herpes, and herpetic encephalitis, inflammation of the brain, meninges of the brain. So, herpetic encephalitis. Now, let us see the options. Which amongst the following is the secondary manifestation of acute herpetic gingivostomatitis? Option A is herpes labialis. Yes, it is. Second is herpetic stomatitis. Yes, it is. Third is herpetic genitalis. Yes, it is. So, the answer to this question is option number C, which is all of the above. Now, the next question is Tannerella forsythia. Tannerella forsythia belongs to which group of bacteria? So, for this, see, every time it's not necessary that all the bacteria that they are asking you must know, okay? But what you know about Tannerella forsythia is that it is an organism which belongs to red complex, right? It belongs to red complex. Which are the bacteria which belong to red complex? You have to remember the mnemonic which we discussed, which is PTT. PTT is P for P gingivalis, right? T is for Tannerella forsythia, and another T is for Treponema denticola. Now, what are these red complex bacteria? These red complex bacteria are the secondary colonizers. And these secondary colonizers, what are the secondary colonizers? What happens if this is a tooth surface, right? We have studied in our classes that if this is a tooth surface, there is initial formation of the pellicle. Over this pellicle, what happens is there is attachment of the bacteria. So, the first bacteria which comes in contact with the pellicle or the proteins of the pellicle, they will attach there, adhere there, and they will utilize all the oxygen which is present there, right? So, the first bacteria to colonize the tooth are obligate aerobes. They will survive in the presence of oxygen. They will consume the oxygen. When they are consuming the oxygen, what is happening? The amount of oxygen which is present onto the tooth, it is decreasing, right? The amount of oxygen is decreasing. So, the first bacteria here are the obligate aerobes. Now, the next bacteria which are coming here and are attaching, these bacteria can survive in the presence of less oxygen also. So, they are called as facultative aerobes, right, or facultative anaerobes. Facultative anaerobic organisms. These bacteria can survive in the presence also or in the absence of oxygen. Now, later what happens is the environment surrounding the tooth is completely deprived of oxygen, and the bacteria which are next in line, these bacteria cannot survive in the presence of oxygen. They can survive only in the absence of oxygen. These are obligate anaerobes, means those bacteria which do not require oxygen, they can survive only in the presence of carbon dioxide or lack of oxygen tension. It is called as obligate anaerobes. These are the obligate anaerobes. So, all the bacteria which are present in the red complex bacteria, these are the bacteria which are the most harmful and which are responsible for causing this periodontitis, right? So, and they are responsible for causing destruction of the epithelium. So, these are the bacteria which are obligate anaerobic organisms. These are the gram-negative. These are the gram-negative obligate anaerobic organism. The answer to this question is gram-negative obligate anaerobes. Now, the next question, which is the fourth question, is overlapping type of cementum is found. Overlapping type of cementum. So, basically, this question is talking about the cemento-enamel junction. Okay. And cemento-enamel junction, if this is the tooth, right? If we are looking at the tooth like this junction is called as cemento-enamel junction. This junction is called as cemento-enamel junctions. And basically, there are three types of cemento-enamel junctions which are there. Cemento-enamel junction can be of three types. So, in 30% of the cases, this cementum and enamel meet at a sharp line or at a butt joint, that is 90 degrees angle. Okay, so they meet at a sharp line. In 10% of the cases, cementum and enamel means this junction will not be seen. They will not meet. So, cementum and enamel do not meet. And in 60% of the cases, the cementum overlaps the enamel. In 60% of the cases, cementum overlaps the enamel for a short distance. Enamel for a short distance. So, here overlapping type of cementum is found in approximately 60 to 65% of the cases. The answer to this question is this. Okay. Now, the next question is the motion of instrument that is used in a sonic scaler. So, basically, scalars are of two types, ultrasonic and sonic. Sonic scalars were the first scalars which were developed, right? Sonic scalars were the first scalars which were developed and after the manual scalars, and they have less frequency with which they vibrate. So, scalars can be divided into manual, right, and automatic. These automatic scalars can be divided into sonic and ultrasonic scalars. The frequency with which the sonic scalars vibrate is around 4000 to 8000 RPM, and the frequency with which these ultrasonic scalars vibrate, or the tip of the ultrasonic scalars vibrate, is 18,000 to 50,000 RPM. 18,000 to 50,000 RPM. In some cases, it is written 15 to 45. So, the range will be near only, but you have to remember this 18,000 to 50,000 RPM. Now, the tip of the ultrasonic and sonic scalars move differently, and because of this difference in the motions, the different pattern of rotation of the tip, they have different working ends. So, the sonic tip. The tip of the sonic scalar has a circular motion it moves in a circular direction like this, and all the four sides of the tip are working. Okay, but its only disadvantage is it is rotating at a lesser frequency. Now in ultrasonics, there are two types: magnetostrictive and piezoelectric. Out of this magnetostrictive, has an elliptical motion. So the sonic tip has a circular motion. Okay, this is the circular motion. The magnetostrictive has a elliptical motion. Okay, and here also all the four sides of the tip are working. So whichever side of the tip is touching the tooth surface, that will result in removal of the calculus. In piezoelectric, what is happening is the only two sides, it has a linear motion. Okay, it has a linear motion like this. So only two sides or two surfaces at a given point of time are working in piezoelectric scalars. So now let us see the question here. The motion of instrument in using a sonic scalar is circular. Okay. Now the next question. Which part of the implant is marked by the arrow in the given image? Now here in the image you can see that this is what? This is the implant body, right? This is the implant body or a fixture. This is the implant body or a fixture, right? This part is what? This is a, we'll see what is this. So here you can see that this part is completely, this is above the bone and completely submerged into the gingiva, and the gingiva is covering this, right? So it can be either a healing cap, it can be a cover screw, abutment and impression course. Let us see what is the difference between these four. Now a cover screw is what? It gets during the first stage of the surgery. If we are planning to do a two-stage surgery, right? Two-stage surgery means first I am placing the implant, and after 3 to 4 months I'll be placing the tooth. That is what is the two-stage surgery. So if I'm planning to do a two-stage surgery, what I do is I place the implant and cover it with cover screw. Why? Because no fluids or bacterial contamination can be prevented. Okay, so what I'm doing is I'm covering the screw here. I'm completely fixing the screw inside and it is covered by the gingiva. This is how it looks. This is a cover screw. Now in healing abutment or a healing cap, what will happen is that healing cap helps in the formation of contour of the gingiva. So if I am planning to do whether a two-stage or a single-stage surgery, I can place a healing abutment, and that will help in my gingival contour like this, contouring of the gingiva, so that the teeth can accurately come in that contour. And this is what is called as biomimetic preparation. Here we are giving importance to the soft tissue also, not only to the implant but to the soft tissue also. And this is what is called as biointegration, not biomimetic, sorry, biointegration, where the importance is given to the soft tissue also. So healing abutment is a part of the prosthetic component which is placed into the implant and it emerges out of the gingiva. This is the difference between the cover screw and healing abutment or healing cap. It emerges out of the gingiva. This is inside the gingiva. This emerges out of the gingiva up to a certain extent, and it will give gingiva its form or contour. Now, there is something called as healing abutment. Healing abutment, what is it? Is an abutment is a part of prosthetic, or it is a prosthetic component over which our crown will be formed. Okay, so here in the X-ray, you can see that this part which you see here, this is what it is coming out of the tissue, and this is what? This is a healing cap. This part which is completely out and it is straight, this part is what? This is the abutment. Abutment is more longer than the healing cap, and we can take the impression of it. Okay. This part which you see here, this is also a type of abutment. Okay, but the height is less. Now in this picture you can see that this part is completely inside the tissue, right? It is completely covered by the gingiva. So this is what? This is a cover screw. This is a cover screw. The answer to this question is B. Now the next question is, the role of exopolysaccharides secreted by the bacteria is all except. Okay. Option A is synthesis of biofilm matrix. Option B is nutrient source. Option C is protection of biofilm bacteria. Option number D is none of the above. Means option number D is none of the above, means all of the above are the role of exopolysaccharides. So what are exopolysaccharides? Basically the bacteria. If I take the plaque and I study a sample of the plaque, in that sample bacteria constitutes only 10% of the plaque. The remaining part is what? It is polysaccharides. It is formed of exopolysaccharides. These exopolysaccharides are nothing but they are bacterial byproducts which are secreted by the bacteria, and they form a jelly-like substance into which they form a biofilm into which the bacteria are suspended and they are remaining there. They help each other to grow. They provide nutrition to the other bacteria which cannot synthesize their own food. So they live in harmony inside that, and this exopolysaccharide is made up of proteins, carbohydrates, nucleic acids. So this exopolysaccharides, it's made up of proteins, carbohydrates, nucleic acids. So what happens is the bacteria, the bacteria have large amount of nucleic acids. So whenever a bacteria is dying in a biofilm, the components of the cytoplasm are secreted outside into the matrix and they form a component of exopolysaccharides. Now exopolysaccharide is still under research and it is considered as the dark matter of plaque because it is not completely understood what the exact composition of exopolysaccharide is, but some components have been studied and it is found that the carbohydrates or polysaccharides which are present into the exopolysaccharides are glucans, levans, fructans, and these are forming the backbone of the biofilm. So the polysaccharides which have been studied till now, so you have to remember that this is the dark matter of biofilm. Why it is called as the dark matter of plaque? Because till now it is not complete. The exact composition of this exopolysaccharides has not yet been completely understood. Till now some information is there कि okay, this exopolysaccharide protects the bacteria, it helps, provides the nutrition source to other bacteria, it helps, it protects the bacteria inside the biofilm from the host, it protects the bacteria from other harmful chemicals which are there. Okay, it helps the bacteria to evade the host immune response. So this is what is the major role of exopolysaccharides, and the polysaccharide components. The polysaccharide components of exopolysaccharides are levans, glucans, fructans, which have been studied in much detail till now. Okay. So yes, the role of exopolysaccharides is all of the above. So the answer to this question is option number D, which is none of the above. So now in question number 8 says, question number 8 says, in which of these conditions do we see interdental bone lower than the interradicular bone? So basically, let us discuss the options. Positive architecture. What is a positive architecture? If this is a tooth, okay, if this is a tooth, the bone which is present in between these tooth is called as the interdental bone. It is called as the interdental bone. Okay. So, if this is the bone, this bone which is present in between the two teeth, this bone, this is the interdental bone. Interdental bone, and the bone which is present onto the root surface of the tooth, covering the root surfaces of the tooth, is called as the radicular bone. It is called as the radicular bone. Now, if this interdental bone is at a more coronal level than the radicular bone, it is called as the positive architecture. The next option is osseous crater. What happens in osseous crater is, if I am looking at the tooth, the osseous craters are because of the loss of the interproximal bone, and here the facial and the lingual plates are intact. So, if I am looking at the tooth from a proximal aspect, if this is the tooth, okay, this is the tooth and here is the bone. This is the facial plate, this is the lingual plate, and like this type of defect is present. This is what is called as the osseous crater. Osseous crater. This is the facial plate. This is the lingual plate. Now, if both of these plates, facial and the lingual plates, are intact and only there is loss of this bone, interproximal bone, or the bone covering the root surface, which is the radicular bone. So here what they have answered is the interdental bone. This is the interdental bone, right? This is the interdental bone which is present between the two teeth here, and it is at a lower level than the interradicular bone. Okay. So the best option to choose here will be the negative architecture. But if the negative architecture is not given in the options, the answer that needs to be selected is the osseous crater, the second best option to choose. Okay. Flat architecture means both the radicular and the interdental bone are at the same level, then it will be a flat architecture. So here in the option they have given the none of the above and osseous craters. Guys, it's such a question. See, this is a type of confusing question. If in the options, if option D would have been negative architecture, if option D would have been negative architecture, then this was the correct answer. But as in the options, they have not given D as the answer. You have to remember that osseous crater can also be considered as a type of negative architecture. And so here the answer can be osseous craters. Okay. Now the next question is, all of these changes are seen in maternal immune response due to progesterone and estrogen, which leads to increased gingival inflammation in pregnant patients, except. So here, all these changes in the maternal immune response due to progesterone and estrogen leads to increased gingival inflammation in pregnant patients, except what? So the question is asking what are the changes into the maternal immune response that leads to gingival inflammation, and out of these four options, which is not the option which is correct, right? So depression. So you have to remember that in a pregnant patient, there is decreased immune response, right? The immune response is always decreased. So if you have never heard about this topic anytime, just put some logic and remember that in pregnant patients, immune response is always decreased. Even if you don't know that, read the options. What are the options? Option number A is depression of cell-mediated immunity. Option number B is decreased neutrophil chemotaxis. Option number C is increased antibody and T cell response. And option number D is decrease in the ratio of peripheral T helper cells and T suppressor cytotoxic cells. Now, looking at these four options, you can clearly make out that option number A, B and C point towards decreased immunity, and option number C only points towards increased immunity, right? So here clearly the answer, just by logic and not knowing the topic also, you will know that the answer to this question is answer number C. Now this is a table from Carranza. You can take a screenshot of this table and you can just go through it once, that what are the changes in a pregnant patient because of estrogen and progesterone in the subgingival plaque composition, maternal immune response, sex concentration, sex hormone concentration, estrogen, progesterone. What changes they bring about. Estrogen is responsible for increasing in certain bacteria such as Prevotella intermedia because it provides the energy source, nutrition source to Prevotella intermedia. Similarly, progesterone is responsible for vasodilation, increased vascularity, increased gingival inflammation. All these you should know, right? Now the next question is, bilaminar technique for gingival recession means option number A, two adjacent grafts taken to cover exposed root surfaces. Option number B, one free gingival graft and one coronally displaced graft. Option number C. Two subepithelial connective tissue grafts only, and option number D, one connective tissue graft and one pedicle laterally displaced graft. So guys, this is also in this question also there should be two options which are correct, option number B and D. I'll tell you why. Bilaminar, as the name suggests, bilaminar means two lamella. It is a two-layered technique. Out of these, two subepithelial connective tissue grafts will be of no use anywhere. Okay, whenever we are placing a subepithelial connective tissue graft, either we have to cover it with something, a membrane can be used, or we have to cover, and over that we have to cover it with the recipient gingiva, right? So in bilaminar technique, what we do is we have, if there is sufficient width of attached gingiva, we can either take a coronally displaced flap, or if there is no sufficient width of attached gingiva, but on the lateral tooth there is sufficient attached gingiva and sufficient thickness of the gingiva present, we can take the gingiva of the adjacent, partial thickness flap from the adjacent tooth. So here what is done is, here a sufficient attached gingiva is present, so a coronally displaced flap is taken and a subepithelial connective tissue graft is taken, SCTG is taken, it is placed and it is covered with the coronally displaced flap. This is a coronally displaced flap, and this is after healing, okay, after healing of 6 months. Now here in the image only you can see that this is a coronally displaced flap, but it's not necessary that always we should take only coronally displaced flap. We can do a bilaminar technique even with the laterally displaced flap. So if in the options it is given that subepithelial connective tissue graft along with the pedicle graft can be coronally displaced or laterally displaced, right? Then that should be the correct answer to select. But here as of now both B and D are correct answers, guys. Now the next question. Which suture is best suited for GTR and other regenerative procedures? Which suture technique is best suited for GTR and other regenerative procedure? Option number A, horizontal mattress. Option number B, vertical mattress. Option number C, loop. And option number D, anchor suture. Now you must know that the best suture for GTR and regenerative procedures is the vertical mattress suture. Vertical mattress suture, and horizontal mattress suture is used in cases of diastema. Okay. So the answer to this question is number B, vertical mattress suture. How a vertical mattress suture is taken is, the needle is penetrated the tissue in a vertical direction from an apically to a coronal direction from the buccal aspect. Then it is taken into the interproximal region, and on the lingual side also similar movement is done from the apical region to the coronal direction, and then it is brought back to the buccal aspect from the interproximal region, and a knot is tied. So you will see that the suture here will be like this. It is called as a vertical mattress suture. Okay. Now the next question is, which phase of periodontal treatment is aimed at elimination of etiologic factors? For this, you must know this table only. Just remember this flowchart and you will be able to answer the questions pertaining to this topic. Always remember that phase 1 is the etiotropic phase, where before phase 1 there is an emergency phase. Okay. If a patient is coming with severe pain in any tooth, we have to treat that emergency first. We have to relieve the pain of the patient, and then only we will move towards the etiology. Okay. So the first phase is the etiological phase, where we treat the etiology of the disease. After phase 1, what we have to do is we have to move towards phase 4 or re-evaluate the patient with the maintenance phase. You have to check the motivation of the patient. In phase 1, you have to do scaling, route planning, any prosthesis, ill-fitting prosthesis is there, ill-fitting dentures are there, some wires are pinching the patient, any orthodontic wire is pinching the patient. All those etiological factors you can treat in phase 1, and after that you have to do a follow-up and you have to check the maintenance. So after phase 1 will be phase 4, which is the maintenance phase. After that you will go to the second phase, which is the surgical phase. Here in the surgical phase you can do periodontal surgeries, implant surgeries. Then you have to you can go to the third phase, which is the restorative phase, where you can give the prosthesis to the patient, whether implant prosthesis, tooth prosthesis, FPD, anything you can give in your restorative phase. So remember that after phase 1 is phase 4. After phase 4, you can directly go to phase 2 or phase 3 depending upon the patient's need. And from there, every time you have to go to the fourth phase, which is the maintenance phase. Okay. Now the next question is, Gracie curate number 11 and 12 are used for. So Gracie curates are the area specific curates, right? Gracie curates are the area specific curates, and there are a set of curates, means they have two working sites. So number 1, 2, 3 and 4 are used for anterior teeth. They are used for anterior teeth. 5, 6 is used for anterior and premolar. Anterior and premolar. 7, 8, 9 and 10. 9 and 10 are two ends of the same tip. 7 and 8 are two ends of the same instrument. Okay. They are used for posterior teeth facial. Posterior teeth facial and lingual surfaces. Facial and lingual surfaces. 11, 12 is used for posterior teeth mesial surfaces. Posterior teeth mesial surface. Sorry. 13, 14 is used for posterior teeth distal surface. Posterior teeth distal surface. So here the answer to this question is 11, 12 is used for mesial surface of the posterior teeth. The answer to this question is question number B. This is one of the frequently asked questions from instrument chapter. Image based questions have also been asked. So this you have to remember. You have to ratify this thing. Okay. Now the next and the last question of this session is, if a patient has furcation involvement with poor crown to root ratio, he should be recalled after periodontal surgery, usually after. For this, what you have to remember is the Merins classification, guys. Merins classification, one another important topic. In this, what happens is, as soon as I have treated the patient, I have completed my treatment on 1st January 2024. So for the first year, it is divided into two parts, for the first year and after the first year. Don't get confused between the two. You have to remember these two separately, first year and after first year. Okay, so for the first year, if a patient has a good oral hygiene, has uneventful healing, and the patient is very well motivated and coming for regular dental checkups, then you can recall that patient every 3 months for the first year. But if a patient has a complicated case, if periodontal surgeries are performed and patient has multiple root canals, multiple prostheses, and you know the patient needs continuous motivation, then you have to recall the patient for the first year at every 1 to 2 months. Now, after first year has been completed, you can divide. You are following the patient every 3 months or every 1 or 2 months, and you can decide whether after first year, how will be the prognosis of the case, and whether the patient will remain motivated, the patient's results will be were good in the first year, were poor in the first year, and accordingly you can divide the patient into class A, B and C. In class A, B and C, you don't need to remember anything except few keywords which are excellent. In class A, what will be their patients who are maintaining excellent results in the first year will be classified as class A, and these patients are having good oral hygiene, minimal calculus, no occlusal interferences, no complicated prosthesis, no more than 50% of the bone loss. So these patients can be recalled. These patients can be recalled at 6 months to 1 year. They can be recalled as at 6 months to 1 year. Now, in class B, the patient has generally, the keyword here is good results, maintaining a good result. For 1 year, the patient has inconsistent poor oral hygiene, some systemic diseases there, but the patient is able to control it, and the patient is a heavy calculus former, the patient has ongoing orthodontic therapy, then you have to recall the patient at every 3 to 4 months. You have to recall the patient at every 3 to 4 months. And the class C patient has a poor result. Patient is having a poor result, heavy calculus formation, many pockets are there, the patient is not compliant, the patient is not maintaining the oral hygiene. You have to call such patient at every 1 to 3 months. Okay. So just remember the keywords: excellence, good, and poor. Now let us come back to the question. If a patient has furcation involvement with poor crown to root ratio, he should be recalled after periodontal surgery every. So this is talking about first year, right? In the first year, how you will recall the patient. So you should recall the patient at every 1 to 2 months. The answer to this question is B. Okay, the answer to this question is B, 1 to 2 months. Okay, so guys, with this we have completed our discussion. We have completed our discussion of NEET GT4, and if you have any doubt in this session, do ask me in the comment section, or you can message us on the Telegram group. And thank you so much guys, all the best.